We're just going to give everybody a couple more minutes to get into our chat room, and then we will start with the chat today on acute lymphoblastic leukemia. Okay, so today I'd like to welcome you all to the 2022 National Virtual Leukemia Conference. This one-of-a-kind conference addresses the unique needs of the blood cancer community and offers the latest information, tools, and resources to help support Canadians affected by leukemia. The Leukemia and Lymphoma Society of Canada is proud to introduce today's presentation titled Acute Lymphoblastic Leukemia, Treatment Options, Managing Side Effects, and Research Advances. In this session, Dr. David will provide an overview of ALL, discuss current treatment options, how to minimize the impact and side effects of treatment, and how research is opening new treatment avenues. Let me introduce myself. My name is Leslie Ann Guiney, and I am the Community Services Lead for Eastern Ontario here at the Leukemia and Lymphoma Society of Canada. I will be your moderator for this online event. Since there are many of you, we invite you to type your questions and comments into the question box of your Zoom webinar panel throughout the presentation. An LLSC staff member will monitor the questions. I will read some of your questions aloud at the end of the presentation during the question and answer period. Due to the large number of participants and limited time, we may not be able to answer all questions. Also note that our speaker cannot answer specific questions about a person's health status. Case-specific questions will not be read aloud during the question and answer period. If we do not get to your question during the live presentation, a community services lead will connect with you directly after the webinar. Today's presentation will also be recorded so that you can listen to it again on our website. You will receive a link to the recording later. Next slide, please. If you have a lot of questions right now, or you cannot find what you're looking for, you can talk to a community services lead like me in your area and receive personalized assistance in finding the answers you're looking for or ways to address your concerns. The community services leads are here to help, and you can reach one of us by calling toll-free 1-833-222-4884. Next slide, please. We invite you to visit the new website, www.bloodcancers.ca. Our goal is to better serve the community and offer an improved experience. On our website, you will find all of our past webcast recordings, our podcast channel, information sheets, and practical tools, and so much more to help you navigate your cancer experience. Please visit bloodcancers.ca. Next slide, please. You can also subscribe and listen to our podcast series, The Blood Cancer Experience, which contains podcasts on a variety of subjects you might find helpful. Here you will find testimonials from people affected by blood cancer, as well as presentations by experts. You can find The Blood Cancer Experience on Spotify, Apple Podcasts, or anywhere you enjoy listening. Next slide, please. It is now time to introduce today's speaker, Dr. David Szwajcer. Dr. David is a hematologist working in Manitoba. He is the Manitoba Blood and Marrow Transplant Program Director. His clinical focus is in treating patients with acute leukemia and related disorders, as well as managing patients through their transplant experience. Thank you for being here today.
Thanks, Leslie. As Leslie was saying, my name is David Szwajcer, and I'm one of the physicians here in Manitoba working on the leukemia service. We have a unique service in that we're a joint adult and pediatric, at least transplant program. And so we have a close working relationship with our pediatric colleagues, although I am, as a disclosure, an adult physician. I have no conflicts of interest. However, I am going to discuss medications used in an off-label fashion, that is not that is medications that are not currently approved. I would like to just take a moment to offer a land acknowledgement. The University of Manitoba campuses are located on the original lands of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene people, and on the homeland of the Métis Nation. So I thought I'd start off by talking a little bit about blood. Blood and blood making is something that all of us rely on. We have a complicated system in our bodies to allow us to make blood. We have stem cells that give rise to all the different kinds of blood cells that we see in our bodies. Blood cells can be divided into two big categories: common myeloid progenitors and common lymphoid progenitors. The myeloid progenitors give rise to platelets, as well as other kinds of myeloid cells, like basophils, neutrophils, and eosinophils, as well as red blood cells. Common lymphoid progenitors give rise to a type of cell called a natural killer cell, which I won't spend a lot of time talking about in this presentation, and also give rise to lymphocytes, which come in two flavors, a T cell type and a B cell type. These cells give rise to T acute lymphoblastic leukemia and B lymphoblastic leukemia, which we'll spend the majority of this presentation discussing. Of interest, there are a series of disorders that have features of both myeloid and lymphoid cells. Those disorders are uncommon, but are seen in clinical practice with some regularity. B acute lymphoblastic leukemia and lymphoma is one type of acute lymphoblastic leukemia. The other major type is T cell acute lymphoblastic leukemia or lymphoma. And there is a rarer type of acute lymphoblastic leukemia known as a natural killer cell lymphoblastic leukemia, which is quite uncommon. Over the last several years, there's been increasing awareness of molecular information. And as the community gains more comfort with using technologies like next generation sequencing and polymerase chain reactions to better define the molecular landscape of acute lymphoblastic leukemia, we're starting to be able to utilize this information in terms of thinking about prognosis and in terms of guiding management for patients with these types of disorders. Over the next half an hour or so, I'd like to give an overview of ALL, then to review the treatment landscape circa 2022 for ALL, to touch on some common treatment toxicities and some approaches to minimize them, and then to spend a little bit of time talking about where treatment might be going. Acute lymphoblastic leukemia is a reasonably uncommon disorder. if one compares ALL to some of the more common forms of malignancy, we know that breast cancer, prostate cancer, and lung cancer affect many more people, for instance, in the province of Manitoba, than does ALL. However, the management of patients with ALL is quite complex, as many on the call are aware. In 2016, there were 6,600 cases that were reported in the United States. The incidence of ALL is reported at about 1.6 per 100,000. In the province of Manitoba, we diagnose about 4 to 5 adults with ALL per year. ALL is primarily a disease of young people. The peak incidence of acute lymphoblastic leukemia is between the ages of 1 to 4. The incidence of ALL drops off, reaching a nadir in the early 20s, and then gradually increases. So it has a U-shaped distribution. About 4 in 10 cases of ALL are diagnosed in adults. And the survival rate in ALL has significantly improved between 1975, which is close to when I was born, in 2009, where survival rates have increased from 31 to 70%. There's been there's a significant variability in the survival rates among those who are young compared to those who are older. We know that children between the ages of 1 and 10 who have favorable risk ALL have a survival rate that exceeds 90% at 5 years. Unfortunately, in adults, while survival is improving, overall, for all adults, survival rates are around 50%, with those who are younger having better survival and those who are older having slightly worse survival rates. ALL has a variety of different clinical presentations. These clinical presentations will exist both when one has a first diagnosis of ALL, as well as during relapse. So sometimes we make a diagnosis of ALL incidentally. Someone comes to their primary care provider or needs some blood work for whatever reason and is noted to have an elevated white count. Sometimes people can have an abnormal complete blood count with derangements in their white blood cell count or their platelet count or their hemoglobin. Sometimes people can have fatigue or bruising. In younger people, T-cell acute lymphoblastic leukemia can sometimes present as a mass in the chest or a large number of lymph nodes. And people with ALL can sometimes have new neurological findings if they have neurological involvement with their underlying cancer. As I mentioned before, outcomes in children are significantly better than in adults. The reasons for this are somewhat unclear, but we know that children have cure rates of greater than 90%, whereas in adults, cure rates are hovering around 50%. One of the major changes that has occurred in ALL management over the last 5 to 10 years is that adult ALL treatment programs have been using more and more pediatric-inspired protocols. Pediatric-inspired protocols were first introduced to treat adolescents and young adults with ALL in the mid-aughts. These protocols are associated with significantly improved outcomes in both younger and not so young patients. we know that these types of protocols can be used in patients up to the age of 60. And one of the things that I just wanted to mention is that even though in adults ALL is more common as people exceed the age of 70, it's less clear how to manage patients who are older than 70. And really, ALL in the elderly is somewhat of an orphan disease without very clear management strategies in the literature to guide treatment. A pediatric type regimen generally follows an approach consisting of an induction phase, which involves either 4 or 5 drugs, along with treatment that treats the central nervous system in the form of intrathecal or introduced into the space of the fluid that bathes the brain and spine. Patients then go on to receive consolidation chemotherapy, which in adults may or may not consist of radiation therapy, and in children definitely does not consist of radiation therapy. The reason that children are not exposed to radiation therapy in general is because we know that radiation exposure in children can give rise to neurocognitive developmental delay. The next step of therapy is usually many weeks in duration, something called intensification. Intensification involves using some schedule of a medication called asparaginase. Asparaginase depletes asparagine, which is critical for ALL cells. Right now, many patients are receiving a long-acting form of asparaginase. So induction, consolidation, intensification will generally take about 8 months. And then maintenance therapy is a treatment schedule that normally lasts to complete about 2 years of treatment. As individuals get older than their teenage years, about 30% of individuals will harbor something called a Philadelphia chromosome. And we know that people who have a Philadelphia chromosome will respond to a class of drugs, excuse me, called tyrosine kinase inhibitors, 2 of which are called imatinib or dasatinib, which are pills. And that is treatment that can go right through one's treatment. There are many complications that can happen to patients getting ALL therapy because much of the treatment involves giving steroids. A lot of patients are prone to infectious complications, especially with viruses. People during intensification can also develop complicated types of bacterial infections. Because patients are exposed to steroids throughout a treatment regimen, a variety of medium and long-term toxicities can arise. Many patients will develop type 2 diabetes, which hopefully will resolve when the steroids are stopped. Some rarer complications involve a condition called avascular necrosis. In ALL therapy, the most common site of avascular necrosis are the hip bones. Prednisone and dexamethasone will decrease blood flow to the bones and cause a constriction in the femoral arteries, and that leads to a condition called avascular necrosis. And some people require hip replacement if they develop that complication. And another complication that can occur is osteoporosis, again because of steroids. Asparaginase, which I mentioned before, can give rise to pancreatitis. One of the drugs used in induction and intensification belongs to a class of drugs called anthracyclines. Anthracyclines are toxic to the heart, and people can develop cardiomyopathy or a decrease in their ejection fraction. Many of the drugs we use can give rise to tingling in the fingers and toes, neuropathy, and a late complication with chemotherapy, not specifically in ALL, but all forms of chemotherapy, is that sometimes we can see late secondary malignancies, specifically blood types of cancers, as well as less common forms of solid tumor malignancies. So I'd now like to talk a little bit about common treatment that was far more common in ALL probably a decade ago, still has a role, something that I spend a lot of time talking to patients about, and that is the role of allogeneic stem cell transplantation in ALL. I know some of you on the call might have undergone or are contemplating undergoing an allogeneic stem cell transplantation. This therapy is complicated, but I thought I would review the therapy in one slide. So an allogeneic transplant involves taking cells from a donor and then giving it to the recipient or patient. So the patient gets chemotherapy to allow their body to accept cells from somebody else. The donor undergoes a collection procedure where their stem cells are collected, usually from the peripheral blood. The stem cells are taken to the lab, and the cell bag is labeled appropriately, and then the patient receives the stem cells. There are lots of things that happen around this for both the patient and the donor, but in summary, that is the process of allogeneic stem cell transplantation. Allogeneic transplantation continues to be very uncommon in pediatric age groups. It was far more common in the past few decades, but as we've gotten better at treating adults and children with ALL, we are doing far less allotransplants in ALL. ALL is not particularly sensitive to the effects of the immune cells of the donor in the patient. And we do have much better upfront treatments for patients with ALL. The last large randomized study looking at the role of allotransplantation in ALL was published in 2012. We know that people who have minimal residual disease at the conclusion of induction therapy are good candidates to consider an allogeneic transplant. People who have relapsed disease are also good candidates to consider a transplant. And sometimes patients can develop treatment toxicities that would preclude continuation of their treatment. And at that juncture, consideration could be given to an allogeneic or sometimes an autologous, where we use the patient's own cells as a transplant source in the setting of high-dose therapy and stem cell rescue. There are a variety of novel treatments that are being explored in ALL treatment. I will review some of these. Blinatumomab is what's called a bispecific therapy that is available to treat patients with relapsed ALL or who have minimal residual disease. I will spend some time talking about CAR T cells, as well as monoclonal antibody therapy. And in this case, I will talk about inotuzumab. Inotuzumab, CAR T cells, and blinatumomab are therapies that are used to treat B-ALL. There are a variety of different conditions or a variety of different drugs that are currently being explored to treat T-ALL, as I will get to. One of which that is gaining a lot of excitement in the literature is a medication called daratumumab, which is used to treat other forms of hematological malignancies, but appears to have activity in T-cell ALL. Blinatumomab is the first licensed drug in this class of bispecific T-cell engagers, which is used to treat B-ALL. BiTE involves a target which binds the T-cell as well as the tumor cell. And it basically brings the T-cell in contact with a tumor cell, and the T-cell is what's called a cytotoxic T-cell or a killer T-cell, and this acts as an immunotherapy to get rid of the patient's cancer cells. Blinatumomab is indicated for relapsed or refractory disease and for patients who have minimal residual disease. There is continuing interest in seeing whether blinatumomab should or could be used in the upfront setting. Blinatumomab is given as a continuous infusion by an infusion pump for 28 days. Normally, it's given for 28 days. Patients then get a 2-week break, and then they would get another 28-day cycle. And this could be repeated for up to 6 cycles. A special consideration with BiTE therapy is that patients can sometimes develop a significant inflammatory challenge, something called cytokine release syndrome, which can make them quite unwell. Occasionally, it can require patients to get admitted to the intensive care unit for a variety of different interventions. But most patients who get blinatumomab therapy will have minor cytokine release syndrome. Monoclonal antibody therapy is another form of therapy that's used in B-cell ALL. There is a drug called inotuzumab ozogamicin, which has an antibody, anti-CD22, which is found on B cells. And this antibody is linked to a toxin called calicamycin. This treatment is administered as an injection as opposed to blinatumomab, where patients are on a continuous infusion pump. Inotuzumab is given as an injection, one injection, and then another injection several days apart. Inotuzumab is used in the relapse setting. Inotuzumab, because of the calicamycin component, can cause significant liver toxicity and can give rise to some challenges with allogeneic stem cell transplantation. It may not be a good fit for someone who's planning on getting an allogeneic stem cell transplantation. Chimeric antigen receptor therapy is something that's gained a lot of interest in the lay literature. Chimeric antigen receptors are genetically modified sensing targets that are introduced into an immunological cell. In the setting of B-ALL, generally the commercially available CAR-Ts have a recognition domain for CD19, which are found on B cells. All the CARs also have a signaling domain, which can be best thought of as an on switch. So a recognition domain that will recognize a target on the cancer cell, and then complicated on switches. CAR T therapy, again in one slide, is therapy that can be used to treat patients with primarily hematological malignancies. Right now, all the commercially available chimeric antigen receptor therapy are derived from collecting autologous or patient's own T cells. So one collects the patient's own T cells by a procedure called apheresis. One then takes those T cells and then introduces the chimeric antigen receptor into those T cells, and then using a complicated growing mechanism, one expands those T cells. One then packages up those T cells, and after giving appropriate treatment to the patient, infuses those T cells with a chimeric antigen receptor into the patient. Those T cells then expand and then ideally are effective at eradicating the B cell acute leukemia. Currently, there is a commercial CAR T therapy for BALL approved in Canada for patients less than or equal to the age of 25. And there is another CAR T therapy that is Health Canada approved and is under consideration by the various provinces for patients over the age of 25. So there are different flavors of chimeric antigen receptor therapy. There are autologous CARs, and there are allogeneic CARs. Much like allogeneic stem cell transplantation, it's possible to take cells from one person, introduce CARs into them, and reinfuse them into somebody else. There are two different cell types that are primarily used to make CARs. There are natural killer cells and T cells. There are pros and cons to using both kinds of cells. It's possible to have a CAR that recognizes one target. So the commercial CARs currently recognize CD19, but there's interest in looking at CARs that can recognize two targets, CD19 and CD22, the targets that blinatumomab and inotuzumab recognize, or even multiple targets. As I mentioned, commercial CARs uses as starting material the patient's own cells. And some common toxicities associated with chimeric antigen receptor therapy include an inflammatory syndrome known as cytokine release syndrome. People can get a neurological syndrome. It's possible for people to get an activation of their monocytes, leading to a monocyte activation syndrome. And sometime after CAR T therapy, a lot of patients will have low levels of immunoglobulin, and some patients will require immunoglobulin replacement to help them fight infections. There are several new directions in ALL therapy. Clinical trials are exploring the use of drugs like blinatumomab, a BiTE, and antibody drug conjugates like inotuzumab in the upfront setting. Various companies and research teams, including our own, are looking at how to optimize chimeric antigen receptors for both B and T ALL. There's a lot of interest in looking at repurposing drugs to treat T-ALL. I mentioned daratumumab, which is an anti-CD38, and there's interest in looking at ruxolitinib, which is a JAK-STAT inhibitor that's used in myelofibrosis. One of the interesting things that's emerging, as I mentioned, young children with favorable risk disease have survival rates that exceed 90%. And one of the big pushes in the pediatric literature and pediatric research is to try to de-escalate care for those with favorable risk ALL to try to minimize long-term toxicity. One of the major improvements in the last decade or so in pediatric ALL was to remove radiation therapy in the treatment of favorable risk ALL, which really has a significant impact on children in terms of their neurocognitive development. There are other approaches in terms of minimizing chemotherapy exposure. We know from the published literature and systematic reviews that chemotherapy administration or high-dose chemotherapy administration can affect neurocognitive development as well. And so there's a lot of push in the pediatric world to try to minimize long-term toxicity given the favorable prognosis of patients with current treatments. So ALL is an uncommon leukemia. The adult treating community has learned much from our pediatric colleagues. However, I'd like to think that they may have learned a thing or two from their adult colleagues. I quite enjoy my interaction with our pediatric team at Cancer Care Manitoba, and I think we've learned a lot from each other on how to better care for patients with complex hematological disorders. ALL continues, outcomes for ALL continue to improve, and immunotherapy is playing an increasingly prominent role in the management of patients with both B and T cell ALL. So with that, I would be happy to answer any questions you might have. Thank you for your time.
Hi there. Thank you for your time as well. So we do have some questions. Excuse me. We do have some questions. It's time for question and answer period. If you haven't done so already, please be sure to use the question and answer box in the Zoom webinar panel to type your questions in. As mentioned earlier, due to the large number of participants and the limited time, we may not get to all of your questions. And if we don't get to all of your questions, during the live presentation, a community services lead will contact you directly after the webcast. So, Dr. David, the first question I'm going to ask you is ALL genetic?
So I think the person is asking if ALL can be inherited. It's possible for, at least in adults, it's highly unlikely for ALL to be an inherited problem. Within the realm of pediatrics, there are a variety of disorders that can give rise to acute lymphoblastic leukemia, including disorders like Fanconi's anemia. And in that context, ALL can be an inherited condition or genetic.
Okay, so our next question is, could you talk a little bit about what the symptoms of recurrence might be, what people might need to look for?
Yeah, so as I was alluding to in the slide in the presentation, the recurrence can sometimes be an incidental finding. So you're followed closely by your care team and someone notices a change in your blood work. Sometimes the patient will notice they feel differently, they're more fatigued, or they might have more bruising. Sometimes individuals might notice some lumps or bumps on their bodies. And sometimes individuals might notice that they're having new neurological symptoms. So ALL can present in multiple ways. It's important to make sure that if people have any concerns at all and have a prior history of ALL, that they bring it up to their healthcare team in a timely fashion.
Okay, thank you for that answer. So the next question we got was, do blood cancer patients with one type, for example, CML, ever develop a second or different type of blood cancer, for example, ALL?
So it's possible for patients with chronic myelogenous leukemia to progress to something called blast crisis, which looks like an acute leukemia. There are two flavors of blast crisis. Patients can have a myeloid blast crisis, which looks a lot like an AML, or a lymphoid blast crisis, where their disorder looks a lot more like BALL. It's also possible for patients with one type of hematological malignancy that arises in the myeloid compartment, to develop another malignancy in the lymphoid compartment. So while it's uncommon to have someone who has chronic myelogenous leukemia develop an ALL or a de novo ALL, it is possible. A lot of times what we see is that someone has a CML and it goes on to progress to a CML and lymphoid blast crisis. And the way that we would distinguish the two conditions is to look at, for instance, their chromosomal abnormalities and see what's happening with a chromosomal abnormalities commonly found in CML, something called a Philadelphia chromosome, which I mentioned in my presentation. There are particular kinds of Philadelphia chromosomes that we more commonly see in ALL than in CML. And if one has the same chromosomal abnormality that one had when one had the original diagnosis of CML, as someone goes on to develop a blast type event, that would more strongly suggest that's a CML and lymphoid blast crisis rather than a de novo acute lymphoblastic leukemia. That being said, the management strategies for both of those conditions would be similar.
Okay, thank you for that answer. So the next question is, why are steroids so common in ALL treatment? And the person at the end of that puts, I don't hear about side effects caused by it as much as in other blood cancer treatments.
Steroids, so acute lymphoblastic leukemia cells are very sensitive, are very sensitive to the effects of steroids. As opposed to many other therapies, we know that it's possible to normalize people's blood counts in ALL very quickly with steroid therapy. And so steroids are considered the backbone of ALL therapy. Unfortunately, drugs like prednisone and dexamethasone do come with a very long list of side effects. They cause both short-term side effects as well as more longer-term side effects, as I alluded to in the presentation.
Okay, that's a good answer. So the next question we have is, how do you mobilize the stem cells of a donor?
So there are really two ways to collect stem cells from a donor. One is with a peripheral blood stem cell collection. When we do a peripheral blood stem cell collection, we usually ask the donor to take a pharmaceutical called granulocyte colony stimulating factor. We all produce granulocyte colony stimulating factor. What GCSF does in pharmacological doses is it loosens the stem cells from the marrow and allows them to go into the peripheral blood. We then collect those stem cells from the peripheral blood using a procedure called apheresis. The other way to collect stem cells is with something called a bone marrow harvest, where we take the donor to the operating room and then aspirate bone marrow stem cells from the marrow cavity. Usually we aspirate about 1 liter of stem cells. A bone marrow harvest generally requires a general anesthetic. It is also possible to do a bone marrow harvest under epidural anesthesia. By and large, the majority of patients in North America who undergo stem cell mobilization or stem cell collection, or donors who undergo stem cell collection, undergo a peripheral blood mobilization strategy rather than a bone marrow harvest.
Okay, thank you for that. The question that just came up was, would an auto transplant ever be used for ALL?
So historically, people looked at auto transplant as a way to treat ALL much more commonly. I think the times that our center thinks about using auto transplant in ALL is in the setting of someone who has evidence of a pH positive ALL or a Philadelphia chromosome positive ALL, who's entered a molecular remission so that they have no evidence of circulating transcript, and where there's a thought about abbreviating their course of therapy. So rather than giving 2 years of therapy for whatever reason, person wants to return back to work, person's fed up with treatment, patient has side effects from treatment. In that situation, doing an autologous transplant might be beneficial. Sometimes people can run into lots of problems with asparaginase toxicity, especially in intensification, where we need to abbreviate treatment. And if we abbreviate treatment, and we know someone is minimal residual disease negative, that is, we can't detect evidence of minimal residual disease in their marrow, then one approach could be an autologous transplant with high-dose therapy. I will say that autologous transplant in ALL, for a variety of reasons, is not as commonly considered as an allogeneic transplant, but I still think, and our program thinks, it does have a place, and we will consider it in a subset of patients.
Thank you for that. So this question is, you mentioned that inotuzumab would not be recommended as therapy prior to a transplant. Can you expand on that a little bit?
It's not that it's not recommended. Inotuzumab can cause challenges in the liver. We know that patients who go to transplant need to wait several weeks before they have a transplant. The reason, or the concern, with inotuzumab and allogeneic stem cell transplantation is that patients who get exposed to inotuzumab can go on to develop a somewhat uncommon toxicity with transplant called sinusoidal obstructive syndrome, which can be a major toxicity associated with transplant that can lead to being rather unwell, or in some rare cases leading to death. And so there are occasions where inotuzumab is the preferred treatment, and your treatment team would be able to address that with you. But it is important to consider a washout period if one is using inotuzumab before one considers undergoing an allogeneic stem cell transplant, because of the risk of toxicity associated with the development of sinusoidal obstructive syndrome after the transplant.
That's great. How common are reactions to intrathecal injections of chemotherapy drugs?
By and large, most people tolerate intrathecal administration of chemotherapy reasonably well. Most patients will develop a headache that's usually short-lived to intrathecal chemotherapy administration. Less commonly, it's possible for individuals to get CSF leak as a function of having a lumbar puncture, and it's possible for people to develop something called an aseptic or a non-infectious meningitis. That's inflammation of the lining of their spinal cord and their brain with chemotherapy administration. An aseptic meningitis happens in less than 1% of individuals who get intrathecal chemotherapy. Headaches happen universally at some point in people's intrathecal chemotherapy experience, but most patients have short-lived headaches.
Okay, thank you for that. I think we're going to have 2 more questions and then we'll wrap up. So you mentioned transplants are becoming less common. Are stem cell transplants more common in pH plus patients? And if so, why do you think that is?
Historically, Philadelphia positive patients were considered to have high-risk disease. Over the last decade or so, it's been recognized with the introduction of drugs that specifically target the Philadelphia chromosome, tyrosine kinase inhibitors, that outcomes of patients with Philadelphia positive ALL in adults is actually better than in those that don't have a Philadelphia chromosome. And so treatment is actually being de-escalated for those patients as compared to patients who are Philadelphia negative. And so right now, it's not uncommon to avoid a transplant in patients who are Philadelphia positive.
Okay, and I think the last question we're going to ask is if you have BALL, can you expect your immunity will be mediated by your T cells? Will it take longer for you to heal?
So in someone with BALL, when they are first diagnosed, their T cells and their B cells are not their normal T and B cells are not functioning well. So the cancer cells produce signals to try and shut those normally functioning immune cells down. Over time, however, we would expect that assuming patients get into remission with their induction therapy, that their T cell function and their B cell function will improve. One of the major challenges with treating patients with BALL is that we use drugs like prednisone, which inhibit the immune system, T cells, B cells, NK cells, monocytes, etc. And so with the treatments that patients get, they do have a acquired immune deficiency, but they are able to fight most infections reasonably well.
Okay, well, thank you so much for that. Could we go to the next slide, please? Oh, sorry. Yeah, there we go. So before we sign off today, I would like to remind everyone of our other conferences that are happening this week. So there is one for AML. It is called What It Is, How It's Treated, and What's on the Horizon. That would be on November 8th at 2 p.m. Eastern Time. CLL, What It Is, When to Treat, and What's Ahead it will be on November 8th at 4 p.m. Eastern Time. CML, What It Is, How It's Treated, and Minimizing Side Effects will be on November 9th at 1 p.m. Eastern Time. And then we have our Living and Feeling Your Best with Leukemia, How to Identify and Manage Side Effects at Home on November 10th at 2 p.m. Eastern Time. Next slide, please. I would also like to highlight the special webcast presented by Ryan Clark, Senior Vice President, Advocacy and PR at CRG Eversana Canada Incorporated, on a very important topic of advocating for yourself and your loved ones. This will be held virtually on November 30th at 3 p.m. Eastern Time. To find out more about that, please visit our website, www.bloodcancers.ca/events. Next slide, please. We would also like to thank AbbVie, AstraZeneca, Bristol Myers Squibb, and Pfizer for their support in making these conferences possible. Next slide, please. Please remember that we are here to help you. You can reach out by email, by visiting our website, or by calling our toll-free phone number. Please note that a short survey will be sent to all participants after the presentation. Please take a moment to respond so that you may help us plan beneficial events for you soon in the future. Thank you for being here with us today. Be well and stay safe.